Welcome. My name is Lou Berman. I'm a full-time endodontist in Annapolis, Maryland. I am also the co-editor and contributing author for the endodontic textbook, Pathways of the Pulp. I've been a SPEAR Study Club member for about 6 years. It's really enhanced my ability to work more effectively and better understand my interdisciplinary team, as well as enhancing my overall knowledge of dentistry. Endodontics is an integral part of this interdisciplinary team, and this video module will describe just one aspect of how the endodontist can be a vital participant in the treatment planning process. The objectives of this module is to understand the various types and stages of root resorption, to understand the management and treatment planning for the various types of root resorption, and to understand the implications of root resorption in a comprehensive interdisciplinary treatment planning approach. The presentation is meant to be an overview, as there is obviously a lot more we could talk about. I would suggest you view the other SPEAR online courses and talk with your endodontist to learn more information. As we define resorption, resorption is the dissolving away of tooth or bone. There's a physiologic resorption, which is a natural process like root resorption of primary teeth. But there's also the pathologic process. This is the process of resorption from a disease state. So the process of root resorption, generally speaking, is if there's damage to the predentin or the precementum, root resorption can occur. If there's a presence of predentin and precementum, root resorption will not allow the osteoclast or the odontoclast activity to occur. However, if there's damage to the periodontal ligament and the dentin on the root surface, this allows for osteoclastic and odontoclastic activity to occur. There are several types of root resorption: surface resorption, internal root resorption, external root resorption, inflammatory root resorption, and invasive cervical root resorption, and we'll spend a lot of time talking about that last one. As far as surface resorption goes, it's not visible on the radiograph. It's a natural process. It happens over and over again on the natural tooth during the course of its development cycle. Internal resorption is a little bit different. The causes, we'll get into that. Sometimes it's possibly trauma-related. Sometimes it has to do with occlusal trauma. It could be physical trauma that actually causes that internal resorption to occur also, and there may be a small infective component associated with that. As you look at these radiographs, you'll see the internal resorption on each of these 3 slides. The cause, again, we really don't know about, but what you'll see radiographically is a punched out radiolucency. It's a ballooning out of the natural canal space. You don't see the canal running through it. You actually see an enlargement in that canal space where that internal resorption is. Some studies have suggested that there may be some correlation with this in addition to trauma to varicella zoster virus, which is a virus that's responsible for chickenpox and for shingles. As you see this diagrammatically, we'll see that the odontoclasts actually eat away from the inside of the canal space to make an almost symmetrical looking punched out radiolucency in the canal space. If you look at this histologically, you'll see a Brown and Bren stain on this slide, where you see a darkening in the area of where the caries would be coronally and also in the area of the internal resorption. That darkening is where there is some type of infection going on. So it is speculated that internal resorption might have some type of infective component associated with that. So let's look at this radiographically. Again, when we look at this, we can take a radiograph from several different angles, and the resorption doesn't seem to change too much. We see that same symmetrical radiolucency in the middle of the canal space. If you look at this diagrammatically, if there's a defect in the middle of the canal, no matter what angulation we take that x-ray with, we can see that the radiolucent area doesn't really change much in its location. However, if it's an external resorption, as you take a radiograph from a couple of different angulations like you see here, you see that the location of the radiolucency changes a little bit horizontally. And that's because as you take a radiograph and there's a defect on the outside of the root of the tooth, as you take it from various angles, you'll see that that resorption will actually change. If you look at this diagrammatically, there's a canal space that you can see right through that resorption defect. So we know that the resorption here is not coming from inside the canal space, it's coming from outside the canal space, an external resorption lesion on the outside of the root of the tooth. Again, here's another couple of images of radiographs that are taken of the same tooth on the same day, but taken at different horizontal angulations, and you can see that the radiolucency moves around on the canal space and on the outside surface of the root of the tooth. Here's another example where you don't really see much resorption on the root of the tooth here at all, but taken at a different angulation, you can see an extensive amount of root resorption there. As we look at this using cone beam technology, it's been a tremendous asset for the endodontist. On the radiograph that we see at the top here, there's obviously some type of resorption defect. But when we take a cone beam of this, we can see that there is a symmetrical enlarging of the canal space itself. And then on the axial image, we can see that there's a tremendous amount of tooth structure loss from the inside of the canal. We don't see a canal space on the inside of that. That's a narrow lumen that you would expect. We actually see a large enlargement of that canal space consistent with internal root resorption. So if you look at a case like this, where there is obviously some root resorption going on inside this canal space, so large that it might even approach the outside of the root of the tooth, I want you to pause the video now to get a better idea of what you might do to take this defect through your interdisciplinary training and decide how you want to manage it endodontically or restoratively. So pause the video now, discuss it, and we'll come right back to it. So welcome back. I hope you had a good discussion of this. In this particular case, we're concerned about the possibility of this resorption extending beyond the confines of the root of the tooth, possibly into the periapical tissues. So to manage this case, we want to do conventional endodontics on the apical part of the root of the tooth. But in that area where that resorption is, we want to make sure that we understand that the gutta percha and sealer might not do a great job sealing that defect between the inside of the root of the tooth and the outside of the bone. So apically, we can fill that with conventional gutta percha, but in the inside of that tooth, inside that resorption defect, we would want to fill that with something that would be biocompatible to the surrounding bone and allow any bone to heal in that area where there may be a perforation from the inside of that resorption to the surrounding bone. So in this particular case, we manage that by filling up the inside of that resorption defect using MTA, mineral trioxide aggregate. And you can get that in a lot of different forms that are out there. But what that material has as a unique property is it allows bone to form right up to that material. So in a case like this where there may be some communication between the inside of the root of the tooth and the outside of the root of the tooth through that internal resorption, managing this internally by placing MTA into that area is really what you want. Understand there's other types of internal resorption that aren't necessarily pathologic, but something that can happen. Here's a case where there's extensive amount of root resorption, mostly apical, that was secondary to orthodontic movement, possibly going too fast. We see an apical root blunting in a case like this, and sometimes we'll even see a little bit of mobility in those roots. But then we also have the natural process whereby a primary tooth, under a natural situation, has their root surfaces that resorb from a succedaneous tooth that's coming up underneath of that. It's a physiologic process that happens on erupting teeth, and sometimes it happens when you don't want it to happen. For example, when there's an erupting third molar into the root structure of a lower second molar, where a lot of root structure can be damaged pretty quickly. Another reason for considering the removal of third molars before this actually happens. And of course, we see that on incoming teeth, not just from orthodontics, but from an incoming canine that may be doing some destruction to the apical parts of the roots that are remaining behind on the permanent teeth, like an erupting canine tooth here. And then we have situations where we really don't know why the roots of the tooth would resorb. Here's a case here where there is a tooth that was treated endodontically, albeit not all that well, where there's a lot of tooth structure that was never cleaned out and never obturated during the original root canal treatment. And here we are 3 years later, where there's an extensive amount of not just bone loss there, but apical root resorption, possibly because either of an inflammatory reaction or an infective reaction in that area. But we also see a tremendous amount of resorption secondary to traumatic injuries. This is a case where there's an extensive amount of inflammatory resorption and a tremendous amount of dissolving away of the root of the tooth. This may be infective in origin or it may be inflammatory. What we typically see in a case where there is an avulsion is root resorption, where the bone is actually growing into the root of the tooth, replacing that root with bone. And here we are histologically, where we can see the bone on the left that's actually invading into the root of the tooth on the right. So in a case where a tooth is knocked out, where there's an avulsion, sometimes the management of that root surface isn't all that ideal. So when the root of the tooth is replaced back into the mouth, sometimes the bone actually fuses to the root of the tooth. Unfortunately, if that happens, the root of the tooth gets locked into the tooth, like for an example in a case like this of this 10-year-old, where the rest of the teeth are erupting, but this particular root of the tooth is locked into the bone and it does not erupt. So this is a pretty typical scenario that we see when there is a replacement resorption from an avulsed tooth. What we also typically see radiographically is the loss of the periodontal ligament along the long axis of the root of the tooth. Fairly easy to see even on a two-dimensional radiograph, where you lose the periodontal ligament around the root of the tooth and the bone is actually observed to be growing into the root of the tooth. Replacement resorption. We would also call that ankylosis. Here's a case here. If you look at it very carefully, the endodontics was done. It was an avulsed tooth, but you lost that delineation of the periodontal ligament around the root of the tooth like you see on the adjacent teeth. There's also an inflammatory resorption, which can happen very, very rapidly. So instead of the root of the tooth being locked into the bone, with the bone replacing the root of the tooth, the bone actually causes a dissolving away of the surrounding root structure. We would call that an inflammatory resorption. So the radiographs that you can see here progress from left to right, where the root of the tooth becomes completely eaten away to a point where when it's extracted, all you see left behind is the gutta percha that was placed up inside the root of the tooth. We would call that an inflammatory resorption. And we see this especially on teeth that have undergone an avulsion. Here's another example of that, where we can see first on the left an internal resorption where the root of the tooth is relatively intact except for the inside core, where the canal space is actually enlarged into that area where it dissolves away a lot of root structure. And then in the middle picture we see a radiograph of inflammatory resorption on both of those central incisors, where the root of the tooth is dissolving quite rapidly. You'll also notice there that the canal space inside there is relatively immature, very wide, and possibly because of the inflammatory exudate that's inside those roots, it causes an underlying inflammatory resorption where a lot of the root of the tooth has been eaten away. And then, of course, on the right is replacement resorption, whereas instead of having the root of the tooth dissolving away like you see in an inflammatory process, we see the root of the tooth actually being replaced by the bone. So these are the three types of resorption that we've discussed just now, but there's another resorption that I want to get into, and that's an invasive cervical root resorption. This is pervasive. We're seeing more of this now than we've ever seen before. And it's a dissolving away of the root structure, typically in a cervical area of the root of the tooth. So diagrammatically, it might look something like this, an invasive cervical root resorption. Now, I want you to take a look at the radiograph here, where you'll see intact canal space, but coronally in the coronal third of the root of the tooth, we'll see an extensive amount of root structure there missing, and you also tend to see the canal space running through that. That's a resorption on the outside of the root of the tooth that starts through a portal of entrance cervically, and it eats away a lot of tooth structure there. I want you to pause the video right now and within your interdisciplinary group, decide how you might want to manage this on a clinical level. Invasive cervical resorption has undergone many different iterations as far as its name goes. It's also known as just plain cervical resorption, or extra-canal invasive resorption, which seems kind of like a strange name. It doesn't mean that there's another canal there. It means that the invasive resorption is happening outside the canal, extra canal, to the outside of the canal space. There's also a terminology that's been used called subepithelial external inflammatory resorption, but generally speaking, we call it invasive cervical root resorption. Now, differentiate this from caries. We all know what that looks like. It's more of a brown eating away of the tooth structure that's kind of gummy as far as its texture goes. This is obviously not the same thing. This is not caries. This is a resorption process. So as you look at the following radiographs that we have on the screen, you'll see something in common with all of these radiographs. You'll see an extensive amount of resorption in a cervical area that extends both coronally and apically. But if you look really carefully, you'll see that the natural canal space kind of runs through that resorption defect. So we know that the pulp canal space is intact, but there's something going on around the outside of that canal space. It's a cervical invasive root resorption that's happening there. Here are some more radiographs, and you'll be able to see even more clearly. There's obviously some radiolucent areas there in the coronal, mostly cervical part of the root of the tooth, where the canal space is intact, but a lot of tooth structure is missing, and it extends mostly cervically, going in an apical and then eventually a coronal direction. So the characteristics of an invasive cervical root resorption is, again, typically it appears cervically. There's a portal of entrance, which we'll be able to show you soon, both radiographically and histologically. And there tends to be a vertical extension going both apically and coronal to where that cervical resorption actually starts. The characteristics is that they're unpredictable. There's an unpredictable speed of how fast and how extensive this resorption will actually happen. And surprisingly, it happens usually in multiple teeth within the same mouth. Typically, patients having invasive cervical root resorption are asymptomatic. The pulp is not affected by this cervical invasive resorption. Typically, these teeth remain vital. The pulp remains vital inside these teeth, especially in the early stages. But as the later stages happen, as the resorption gets worse, there's an increased potential for both periodontal and endodontic pathosis to happen in these teeth. This type of resorption mostly affects maxillary incisors and canines. Again, those are the teeth that tend to undergo more traumatic injuries, so maybe that's the reason why we're seeing it more often in the incisors and the canines. We also see it, though, a lot in mandibular molars, less so in maxillary molars. The causes? Well, we see that about 21% or so of these teeth with invasive cervical root resorption have had previous orthodontic treatment. We also see this in about 4 to 5% of cases that we've done internal bleaching too. So there's something going on there that's traumatizing these teeth such that this invasive cervical root resorption happens. That said, about 14% of patients that we see that have a traumatic injury to their teeth have invasive cervical root resorption. And then, of course, there's unknown causes. We just don't know why these happen. Surprisingly, there was one paper that came out that showed that a feline herpetic virus, a virus that's typical in cats, tend to be associated with teeth that have had invasive cervical root resorption. And as you look at cats, and I don't, invasive cervical root resorption seems to occur in about 50% of all cat teeth. So maybe there's some type of relationship here going on. The article that's most quoted about this was an article by von Arx that was done in the Journal of Endodontics about 9 years ago, where it actually talks about an assessment that was done on teeth with invasive cervical root resorption where they found these feline herpetic viruses residing. As you look at these teeth cervically, a lot of times you'll see like a pinkish kind of a hue right there cervically where the invasive cervical root resorption, which is very, very rich in blood supply, as it eats away on the dentin, getting close to where the enamel is, it causes a pinkness there cervically. So that's something you want to look for cervically when you're looking at things. And then as that invasive resorption becomes that much more invasive, we'll see a gingival overgrowth into that area where that resorption is. Again, something that's very classically seen in these cases where there's an invasive cervical root resorption. Diagnostically, you can probe subgingivally, and sometimes with a good explorer you can get up underneath of the gingiva and you can actually probe where that cervical resorption actually is. Radiographically, that's your key. As far as how extensive that is, the cone beam is really your key for trying to assess how extensive this resorption actually is. So as you look at a radiograph, here's a tooth with endodontic treatment that was done, taken from a study done by Rick Schwartz in the Journal of Endodontics about 8 years ago, where you can see the endodontic treatment that was done, but a radiolucent area there cervically. On a cone beam, as you see this, you can see that the resorption is almost completely on the buccal area of that tooth, cervically and a little bit apical to that. And then as you look at the axial slice of that on a cone beam, you can also verify that the resorption defect that you have there is facial. It was labial to the root canal filling material on that upper incisor. So the cone beam is really a tremendous asset in understanding and appreciating how extensive the resorption lesion is in these teeth. Another way we have to assess these cases of resorption is something called a micro-CT. Different from a cone beam, where the cone beam gives you slices about every 0.8 millimeters, the micro-CT is a whole lot more, where the slices that go through the tooth in this case is done at about every 0.6 microns. Really, really small. It takes several hours to do a micro-CT image of an extracted tooth, and it takes another several hours for the software to put all that together. But the advantage is, after the fact, we can remove that tooth and take a micro-CT to see exactly what's going on. What you see in this image of the micro-CT is first an image that's three-dimensionally reconstructed showing the outside surface of what that root looks like, which very much matches up against the photographic image of that tooth. What you see in the section running through the root of the tooth is how you have an intact canal space in there, but along the side of the canal space, you see that resorption, with a delineation between the resorption and the canal space itself. Again, validating that this is an invasive cervical root resorption going in through a portal of entrance and not an expansion of the root canal space itself. Here's another image of that where you can see a two-dimensional radiograph, and then you can appreciate from the cone beam how extensive that resorption is, but again, leaving the canal space intact and eating away just on the root space itself. Clinically, it might not look different to you at all. You might not see any pinkness cervically. You might not even be able to probe anything cervically. But as you look at the radiograph of this, you can see an extensive amount of resorption that's happened as the cervical resorption invades that tooth cervically. Again, to appreciate how extensive this can be, understand that a cone beam is really invaluable when assessing cases of an invasive cervical root resorption. And here we can also see and appreciate that the canal space remains intact, but the resorption enters in, as you see here, where there's a portal of entrance cervically that goes in and eats away a lot of tooth structure there. When the tooth is removed, again, like we saw before, you see an extensive amount of tooth structure loss and very, very vascular. Again, nothing like what caries would look like. This is an extensive amount of tooth structure removal, and it's very, very vascular. To understand how all this is put together, if you want some additional literature on this, there's an article that was done by Mavridou that was in the Journal of Endodontics just a couple of years ago, and it gives you a really good description of this. In addition to that, there's some great videos that go along with this. So if you look at a case on the left where you see an extensive amount of resorption, you can see that the tooth itself might only have a very small portal of entrance that goes in there and mushrooms out a tremendous amount of tooth structure. Again, a classic appearance of an invasive cervical root resorption. And going back to the micro-CT that we used before, Mavridou also looked at this and really beautifully illustrated how the canal space and the surrounding canal space remains intact with a portal of entrance and an extensive amount of tooth structure removed after that. If we take this micro-CT and look at this three-dimensionally, going from the top of the tooth, cervically, and then apically, this is what you typically see. So here we are, we're gliding down the root in cross-section, axially, and as we go from the crown of the tooth down, we start to see the pulp tissue and the coronal pulp. And as we go further down the root of the tooth, you see some resorption around the outside of that pulpal space. We see a tremendous amount of tooth structure from that resorption, and as you look at this video, as we're going down, you'll see at around 6 o'clock on that video a tremendous amount of resorption that's coming in from a portal of entrance. That's a classic sign of what we see in cases where there's an invasive cervical root resorption going in cervically through a portal of entrance and extending both coronally and apically as we go down this micro-CT. Diagrammatically, again, the canal space is intact, there's a portal of entrance, and an extensive amount of resorption that kind of goes around the entire canal space there. Histologically, what we see is, again, if you look right in the middle, there's a little bullet hole there where the canal space is intact and a tremendous amount of resorption on the side. So there are various classifications that we have for invasive cervical root resorption, and again, it depends on how extensive the resorption process is. This was put together by Hithersay. It's a beautiful paper that summarizes all this about 2004. And what he saw and classified as a class 1 is just your most incipient amount of resorption that you can barely see radiographically, and again, it's usually very much cervically. This is what was known as his class 1 resorption. It's a small invasive resorption lesion. It's near the cervical area, and it has a very shallow penetration into the dentin that either you can probe clinically or you can see radiographically. As we progress with more resorption, this is a class 2 defect from Hithersay, where we have a well-defined invasive resorption lesion very close to the pulp chamber, but it's extending a little bit more coronally and apically with little more extension into the radicular dentin. So it's a little bit worse than a class 1. As we get into the class 3 resorption, this is when we have a deeper invasion into the dentin that's circumventing the canal space that now becomes on the opposite side of the canal space. This will show up a whole lot more on a radiograph when it's taken. It's not only involving the coronal dentin, it's actually going a little bit more apically, and it's extending into the coronal third of the root of the tooth. So it's a lot more extensive than the class 2. And no surprise, the class 4 defect is really extensive, where histologically it's really a larger invasive resorption lesion that's, again, starting at the portal of entrance and worse cervically, but extending much more coronally and much more apically. So to identify this, we're looking at a very irregular outline of the resorption with the canal space, as seen radiographically, going right through the resorption defect. So we can typically see that canal space with the overlaying cervical resorption there. Typically in cases like this, and I guess no surprise, the pulp remains vital because that resorption is not going into the pulp itself. Management goals. This is where you need to come together with your interdisciplinary team and understand what needs to be done to manage these types of defect, because it comes into various aspects and disciplines of the various specialties. Your overall goal is to arrest the process of resorption by removing the blood supply to that resorbing tissue. So your management options are: don't do any treatment until there becomes symptoms, extract that tooth with no delay, or enter that defect, clean out that defect if it's possible, and restore that tooth, both subgingivally and coronally. You want to make sure you manage the internal and external approach for clearing up this resorption defect. So if you look at the studies that Hithersay did on the various classifications of invasive cervical root resorption, he had 101 teeth. He had a follow-up of about 3 years. So he found that the class 1 and class 2 defects, he was able to clean that out and restore that with fairly good success, about 90% plus. However, as the resorption got worse, it's harder to clean out and harder to remove, so his success rate was reduced to a little less than 80%. But again, by no surprise, trying to manage a case with a class 4 Hithersay defect is very unsuccessful, with a success rate of barely 12%. And again, that was only followed over a 3-year period of time. My guess would be that the success rate went down over a period of time. So we can manage this defect both internally through a pulpal space or externally. If the case becomes symptomatic and we're approaching it internally, we can actually go into that pulp chamber, go into the area cervically, carefully debride that material, debriding the resorption defect that's in that area of the pulp, cleaning that out and repairing it. This is often possible with a class 1, class 2, or class 3 defect, but sometimes it doesn't work out that favorably. As an internal approach, you want to go in there and, using a burr or a curette, clean out that resorption defect such that there's no more bleeding inside that area, which would be consistent with the removal of that resorption. We can also use a 90% mix of TCA, trichloroacetic acid, on a cotton pellet and place it in there for about a minute. This actually cauterizes that area. The problem with the TCA is if it goes beyond the confines of the root of the tooth and into the bone, it will cause some bone necrosis. So this is tricky material to try to use in that area. Once you've done this, you want to rinse it out thoroughly and dry it. And once that's done, you want to use either calcium hydroxide or MTA to fill that defect. Calcium hydroxide and MTA will have the ability to establish better healing of that bone as it comes close to where the MTA is, as that MTA goes beyond the confines of the root of the tooth. You want to repeat this until you know you have good healing and then obturate your canal. So that's a management going from an internal approach. But keep in mind, if you're using the TCA acid, you want to make sure you're careful with it. It comes in a crystalline form. You can get that at most pharmacies, or it can be ordered. And you just add a drop of water, as much as you can put in there, in order to saturate that TCA to make it more of a paste. This will give you about a 90% concentration of the TCA. And you want to make sure you remove all the excess using water and dry gauze. You do not want this to touch the gingiva. You do not want this to touch the bone. And for that reason, it becomes a very difficult material to use in a case of invasive cervical root resorption. There's also an external approach, which tends to be the most common approach for managing invasive cervical root resorption. We would do this on a class 1, 2, or maybe a class 3 defect. For those defects, they're smaller, defined lesions and easier to get to surgically. And typically speaking, they're more coronal to the alveolar bone and only a little bit more apical to the alveolar bone. And understand that after that external approach is done, some type of restoration needs to be placed in there. So let's go through this a little bit. You want to determine the extent of that lesion, and of course you'll use radiographs and cone beams in order to help understand that. Typically, if the defect is not that bad, you will not need a root canal. There won't be any extension of that resorption into the canal space. So what do? You flap the area, get good exposure of that defect, remove all the soft tissue associated with that defect with a burr or with a curette. You can also place TCA there just for about a minute. And again, because you have direct visualization of the bone that surrounds that, it allows you to be that much more careful using your TCA. Clean it out. After you're all done, dry it out really well. But understand, after you've placed your TCA, you want to make sure you freshen up that crypt in the root of the tooth with either a burr or with a curette, because otherwise the bonding materials have a really tough time attaching to where the area was on the root of the tooth that had the applied TCA. Once you do that, typically this is restored with Gerrestore, and I'll go over that with you shortly. So in a case like this, where you have some invasive cervical root resorption on this lower canine, you flap the area, you can expose the defect where the resorption was, clean it out really well so there's no more bleeding points on the root of the tooth, and place Gerrestore. There's a great review of this and how it's done by Rick Schwartz in the Journal of Endodontics in 2018. So once the Gerrestore is placed into that defect, you put the flap back to where it was, and ideally that flap will adhere to the area of the Gerrestore, which makes it a very unique material for this type of procedure. Optibond can be used. There's some Fuji composites that can be done, but Gerrestore seems to be more the mainstay and has been studied a whole lot more. It's a syringeable composite that's placed in there, and it has been shown that we can establish a connective tissue attachment from the flap that's replaced back on there right directly to the Gerrestore material. There was a study done by Camp in 2003 where it showed that fibroblasts attached immediately to the Gerrestore. Another study that was done by McCann over at the University of Nebraska, who said epithelium and connective tissue were found to adhere directly to the Gerrestore, which is something that you want, because if it doesn't happen after you do this procedure, you'll see a gingival dehiscence there. It'll be a cosmetic and restorative issue. People have asked about using mineral trioxide aggregate for filling up these areas externally to try to repair this. Understand the only reason for using MTA, mineral trioxide aggregate, or some of the other materials like Biodentin by Septodont or BC Putty by Brasseler, the only reason for using this is so that we can encourage bone to grow right up to that. It's not going to happen, and these materials tend to wash out over a period of time if there's any sulcular fluid there. So MTA is not something you want to place in those defects because you're not trying to get bone to grow up there. It's not going to happen, but you want to make sure you're using a material where the flap will reattach properly and you'll get a good connective tissue reattachment to the restore material that you're using. There's a repair phase for invasive cervical root resorption. It starts at the portal of entry of resorption, and the ingrowth of bone is like tissue growing into the dentin. And over a period of time, eventually there's a fusion between the bone and the ingrowth of that surrounding bone. So it almost has a bony type of repair going on inside the root of the tooth. So it breaks it down into 3 phases. There's a resorption phase that we typically see. The resorption tends to progress over a period of time, and there is some resorption repair as that bone grows into the tooth. Is there ankylosis? Yes. Does a tooth remain there? Yes, and that's a really good thing too. So the repair issues, the cervical exposure of that root resorption. If left alone, there can be a downgrowth of that gingival epithelium and plaque and cause a gingival dehiscence in that area. If you have a lack of cervical repair, you'll have that constant resorption going on, eventually eating away a lot of tooth structure, almost having an hourglass appearance of that cervical resorption to a point where the tooth can be just snap off pretty easily. We saw this by Mavridu earlier. This is another micro CT scan that goes through the tooth itself. And as you scan the tooth from the facial aspect to the lingual aspect, again, you can see how much damage can occur here with the resorption starting off at a portal of entry like you see on the right side of the video. You see it extending in to the root of the tooth, but you can also see some bone forming around the outside of that, actually invading into the root of the tooth, repairing that area of resorption. It's a slow process. Sometimes it doesn't happen very often. What's really interesting in this video is as this imaging goes on, the root of the tooth can be flipped over to its side, and you can see how extensive it is on the resorption going on here. And here's the same image as it rotates around. That's where your resorption is. And as this spins around, you'll be able to see how the resorption enters into that root of the tooth, dissolving away a lot of the tooth. But what you'll also be able to notice is that there's some kind of a hard tissue that's also growing into where that resorption is. That's the repair phase. It's where bone is actually grown into where that resorption is, and that's a good thing because it keeps the tooth around a whole lot longer. You can see how this tends to look when the tooth is in an axial direction and you're actually slicing the tooth from the apex going coronally. And you can see where the resorption actually is to the right of the screen, but you'll also see instead of a very vascular material, you'll see that it starts to look a little bit more grainy, and that's where the bone actually enters in to where that resorption is, part of the repair phase of an invasive cervical root resorption. So here's the dilemma. When do you treat these cases? When do you decide, let's just have this tooth taken out? And when do you decide to do no treatment at all and just wait and see? Is that supervised neglect or is that what's in the best interest of the patient? So here's the premise I want you to work with. Resorption will get worse over time. It's not going to stop. It will get worse over time. But the speed of that resorption, how fast that resorption is going to happen, is really unknown. So the premise should be function, aesthetics, and biology. These are the things that are important as far as managing this tooth and keeping you and the patient out of trouble here. So what it comes down to is if you're planning on trying to repair these teeth by an external approach, what's more important, the tooth or maintaining a quality of bone around the root of the tooth? So your options are, should you lose a little bit of bone in order to save this tooth by doing an external surgical repair? Or do we want to remove the tooth in order to salvage the bone around there so it doesn't get any worse, because you know that your external approach is going to damage that much more bone around there and potentially compromise your case for a future implant? So here are your options. No treatment, worry about that tomorrow. Monitor that over a period of time, radiographically and clinically. And case selection is really important. The history, the speed of the resorption. So how long has that resorption been present for? How long can that tooth actually be retained in a case like this? And obviously, you may manage this differently for a 90-year-old compared to a 20-year-old. So what are the potential complications of retaining a tooth with no treatment at all? What's the value of the repair phase along that period of time? So here's a case here that was sent over with some cervical invasive root resorption. And as you see here with that pink line, you can see that's the level of the free gingival margin. And as you look here with this red line, that's the extensiveness that you can see, at least radiographically, for how extensive the apical extent of that cervical resorption is. So because of not great communication possibly, the endodontic treatment was done on this tooth. It was sent over to the periodontist to restore this, place a Gerrestore in there, and then a crown. And this was the final result. So had this been assessed better, communicated better, and maybe a CBCT assessment to see how extensive that resorption is, the patient would have saved a lot of time and aggravation and money by having an unnecessary procedure done. So case selection is really important. It needs to be assessed really well, and it needs to be evaluated both from a restorative point of view, a periodontal point of view, and what are the ramifications if it gets worse? Is it going to compromise the potential future implant there? Here's a case that was sent over in 2009 for an evaluation. You can barely see some resorption on that particular root. We're looking at the maxillary right central incisor, the one on the left, and here we are 4 years later where there's obviously more resorption going on. But here we are about 8 years after the original evaluation that was done, where there's an extensive amount of resorption going on. Patient has no symptoms. In this particular case, you can see where that resorption is and try to get a better understanding that if you flap this area and clean out that resorption, there's no way you're going to be able to do that unless you can truly get up in there more apically to remove all the debris from that resorption. Is that going to compromise things from a periodontal point of view by going in there removing that crestal bone, which a lot of which has already been removed? Is it going to compromise it potentially for a future implant? Those are all things that need to be considered. Here's a case here from 2010. It's a lower second molar where you can see some incipient resorption there in that chamber area. A cone beam was not taken. 7 years later, we can see an extensive amount of more resorption there, which can now be probed subgingivally. What do you do about this? Is this fixable by going in there from an external approach, going subgingival, and removing all that tissue inside there? Or does it make sense to leave it alone? Or advise the patient that this is a future problem and consider extraction right now? Those are all conversations that need to be made within the interdisciplinary team and an approach that needs to be advised to that patient so they can decide along with you what's in their best interest. Here's a case here where, again, you see a little bit of pinkness around the gingival margin there, and radiographically you can see some cervical resorption there. Those are difficult cases to try to manage. So to summarize that, case selection is absolutely important. Cone beam tomography is essential for trying to understand the extensiveness of these resorption defects. But understand that there are periodontal issues and aesthetic issues if you take a surgical approach, and you need to understand the ramifications that can happen if you end up with a gingival dehiscence and even more bone loss subsequent to your treatment. The speed of future resorption is kind of up in the air. It's really hard to tell, and many patients aren't willing to undergo the procedures right now, but with the understanding that the future is going to be extraction of the tooth, they may be willing to just monitor this to see how bad that resorption gets over a period of time and then remove the tooth after that. So the speed of the resorption is almost a flip of a coin. So annual monitoring of this resorption defect is very important. Like all procedures in dentistry, you need to do a cost-benefit analysis. If you're considering the potential for endodontic treatment if there is symptoms from the resorption, if you end up having a periodontal procedure and a restorative procedure on that tooth, what are the costs that are going to be involved, and are you really getting a lot of bang for the buck? Because if a patient is approached with the costs that are going to be incurred during these multidisciplinary treatment plans, the election might be to have the tooth removed and alternatively put in a fixed bridge or an implant in there. So you have to understand what the ramifications are and the cost benefits are, but also understand the ramifications of no treatment at all. So in summary, I hope you enjoyed this video module. Our objectives were to understand the various types of root resorption, to understand the management and treatment for the various types of root resorption, and to understand the implications of root resorption in a comprehensive interdisciplinary approach to diagnose and manage various types of root resorption. Thank you for taking part in this discussion, and I look forward to sharing with you other endodontically related topics in the future.